Well, hello everybody, and welcome to another episode of GU Stephen. This is Declan Murphy, urologist here at Peter MacCallum Cancer Centre, joined as ever by my co-host, Dr. Renu Eapen, urologist here at Peter Mac. Hi, Renu.
Hi, Declan. It's good to be back, and for a very special episode this time. We have a guest, a very special guest we've been waiting to bring on for a while now. But maybe, Declan, you could tell us all how we got here.
Yeah, exactly. As you know, we've had patients on the podcast before. I know a lot of patients, GU oncology patients who listen to the podcast, prostate cancer patients in particular, as well as our big audience of clinicians and researchers working in GU oncology and the GU oncology industry. And of course, prostate cancer is a very large part of that. But I was sent a link to a podcast recently by one of our anaesthetists, and she said, have you listened to this podcast on the ABC with Tim Baker? A well-known author and journalist here in Australia who's been diagnosed with prostate cancer. And I said, oh no, I'll have a listen to that. Love listening to podcasts. You always pick up a few tips. I stuck it on the bike on the way home and literally had to stop a couple of times just to replay what I thought I'd heard, because it was one of the most confronting podcasts I've ever listened to as a clinician, as a person who looks after a lot of prostate cancer patients, and in particular as someone who prescribes and supervises a lot of androgen deprivation therapy, or hormone therapy as we sometimes call it, for men with nasty prostate cancer, because Tim has had this experience of being diagnosed with advanced prostate cancer. He's written a book about it, which we're going to talk about today, and he's recorded a podcast, and it was that podcast that made me stop and think, geez, we need to ensure that more people like ourselves, Renu, who prescribe a lot of androgen deprivation therapy, who look after men like this, have an opportunity to listen to the other side of the fence, to listen to what it's like for a patient like Tim to be diagnosed with prostate cancer and to be on androgen deprivation therapy in particular. So that's what we thought we'd do today, invite Tim Baker on.
And you got a copy of the book, and you got me a copy. Thank you for the wonderful gift. And I read it recently on a flight to the US, and normally I watch a couple of movies and get some sleep, but I could not put this book down. It was, like you said, quite a confronting read, but it also just made me think, we need to be understanding what our patients go through a bit better.
And it's not like it's not a happy book. There's lots of great stories, because he's not just a patient, he's a writer. That's what he does. So he's a great storyteller, and he writes a great story. But it's really important. So I hope those of you who enjoy GUcast really enjoyed this episode, because it's incredibly important. It will make you be a better clinician, be a better researcher, be a better industry person if you better understand this whole experience. So Tim Baker, thank you so much for joining us on GUcast. Good morning.
Good morning. How are you? Thanks for having me.
No, great. Well, thank you for joining us. So we reached out to Tim. I sent him a message on Twitter. He's on Twitter. We'll put all the links in the show notes as usual. And I talked to him on Twitter. I direct messaged him to say was my experience listening to your book. It was extremely confronting and emotional and educational for me to listen to it. And then we wondered, would he come on and tell his story? So thanks very much for doing that, Tim.
And
absolute pleasure.
And on top of that, Tim, it's just such a beautifully written book. You really have a gift with words. And it's just, it was just such a compelling read. So thank you. It was a wonderful book.
And the book,
thanks so much.
We haven't even mentioned the name of the book. Yeah. So the book is called
Patting the Shark.
It's called Patting the Shark. So Tim, we thought we would ask you first of all, why is this book called Patting the Shark? Because that's a great story in itself.
Yeah, sure. Well, I was diagnosed on July 7, 2015. And as you can imagine, my world was abruptly altered. And I can remember waking up about 12 days after my diagnosis, just still processing my new reality, and got on my phone, and every news service was blaring the news of an Australian surf star in a shark attack. And it turned out it was my old mate, Mick Fanning, who I've written a book with a few years ago. In the final of a World Surf League event at Jeffreys Bay, and I think a lot of us have seen the footage of this big dorsal fin suddenly surfacing next to him, and then a wave kind of obscuring him just as he got knocked off his board, and there's a period of about 10 seconds where we can't see what's happened, and we don't know whether we're going to see blood in the water or not. It was pretty dramatic. And I remember watching it thinking, like, what I'm dealing with is almost like a slow motion version of what Mick's going through, facing this mortal threat. And, Mick's a pretty inspiring character, and he famously punched the shark. And I thought, well, I've got to take some inspiration from my young mate here. And there's also a moment where he's swimming towards the beach, and then he stops and he turns around and faces back out to sea, and he's treading water. And he said he wanted, if the shark came for him again, he wanted to be able to face it and to fight it off. And I just thought, what incredible sort of presence of mind. And that's what I'm going to do. I'm going to face it and fight it off. And it was probably about 3 years post-diagnosis, I kind of had this realization that, I can't really be at war with myself. I kind of have to somehow make my peace with this. And perhaps rather than punching the shark, the desired approach is to learn to pat the shark and make my peace with my diagnosis and ultimately make my peace with my mortality. I'd no sooner had this epiphany than I was scrolling Instagram, which is perhaps a strange thing to do, having just had an epiphany. But it turned out I came across a post from Mick filming a documentary for National Geographic, diving with a woman called the Shark Whisperer and literally patting sharks.
Wow.
And I saw that footage and I thought, wow, that's maybe a little bit of cosmic confirmation that I'm on the right path. So yeah, it was all quite serendipitous.
Just amazing. And it is a great read, Patting the Shark. And we're not going to go in today and talk about your huge history as a leading writer about the surf industry, but in itself, it's a great story. How you became a surf journalist, and we'll put links into the great ABC podcast that really goes into that. And I really enjoyed it. But what we want to concentrate today on is your experience as a prostate cancer patient. Oh. And we want to talk about ADT because that's a really big part of your life and your focus. But before we do that, Tim, again, this was a very confronting thing for me to listen to, was you describing how you were diagnosed, how the information was conveyed to you by your urologist. In the book, you write about it. And on the ABC podcast, you talked about it a little bit. Let me just play the clip that I listened to that was actually very confronting for me, Renu, if you don't mind.
He slid a scan up onto his sort of wall-mounted light box, and with a pen, he said, "This more or less confirms our suspicions." And there was just a large white smudge where my right femur or thigh bone should have been on the scan. And then that's when shit really got real. And I couldn't speak. Kirst said, "Can we just back up a minute? Are you saying that's cancer in Tim's leg?" And he said, "Yes." And that's when everything changed. Yeah, that moment.
Yeah, so as a 50-year-old, PSA 120, some urinary symptoms, this is the moment that you write about a lot, to say that that's how I was told. And in the book you described then that experience of, leaving being told hormone therapy, see other oncologists, leaving the waiting room. And I found that dreadful to listen to, because I immediately reflect on how do I communicate with my own patients. But do you want to expand on that a bit more, Tim? And in the book you do, but you also do a great, what did he call it?
A take two,
version
two.
Take two. In the book there's a great take two where he literally almost rewrites, this is, how it may, perhaps this could have been delivered better. So very important for us to read that. But please, reflect a bit more on that.
Yeah. Well, I think at the time it felt pretty abrupt and a bit perfunctory. And I remember just stepping out of that office into the waiting room, and it just this sort of dissonance that, the rest of the world seemed to be just, operating normally, but our world had just been tipped upside down. And the receptionist booked me a couple of appointments with an oncologist and an orthopedic surgeon to see if the leg needed to be pinned for what my urologist had called a pathological fracture, which sounded fairly alarming. So there was just a lot to take in, and we were both just completely shell-shocked. And we just sort of stepped out of there with a handful of referrals and a brochure and a couple of scripts for painkillers, and just looked at each other and sort of went, what are we supposed to do now? And I had a friend who worked at a hospital as a social worker. And I was reflecting on my experience, and I was chatting to her about it. And she was saying, when someone dies in sort of sudden and dramatic circumstances in a car accident or something like that, and there's bad news to be delivered, she might be there to sort of counsel the family and relatives. And I thought, well, I wonder if we could or should be doing something like that when that kind of news is delivered, because it was just so difficult to know what to do. And I mean, my wife and I literally just walked through the vast hospital car park back to our car and just sat in the car and cried our eyes out for I don't know how long. And then, just started trying to process, well, how do we talk to the kids about this? Yeah, it was a really, really rough day, that one.
And in your book, Tim, you know, when it's gut wrenching to read, because you talk about that experience of stepping outside the doctor's office, and you and your wife are just looking at each other, and you can just imagine the loneliness and isolation you must have felt, and the incredible fear of what was going to happen without any real way of knowing how to deal with it. And then in your take 2, you described this wonderful scenario where, you know, despite this horrible diagnosis, you then go ahead and meet with a prostate cancer nurse and a social worker. And it was lovely because at the end you said, now we feel ready and prepared to step back out into the world. And that's quite a different scenario, isn't it?
Yeah, and look, it is a bit of a fantasy, and I don't know how realistic it is amongst the busyness and time pressures of your average hospital. But yeah, I understand urologists and oncologists are often, you know, really time poor. But, you know, prostate cancer nurses, I've had some experience with the PCFA, telehealth prostate cancer nurses and counsellors, and they do an amazing job. And, you know, I just thought if there was someone who could just spend that time with you in that immediate aftermath of receiving a diagnosis like that and just help you begin to, I guess, navigate and visualize the path ahead. And also to, I think, you know, the idea of referring people to a suite of kind of supportive therapies, particularly around things like exercise and nutrition and psychological support, I think would be a great thing. And that's something I'm really keen on sort of advocating for.
Yeah. And we'll come back to that, because as you started to experience androgen deprivation therapy, you started yourself trying to figure out what sort of support and strategies would help mitigate the experience of being on ADT. So we'll come back to that, because you've come up with a quite simple overview of a strategy, a nice acronym about how that might work. But before we do that, we need to talk about androgen deprivation therapy. We need to talk about the effects that had on you. And again, I'm sure you'll describe this to us, but this is another clip from the ABC podcast where you're sort of trying to describe to the ABC person in colloquial terms what it's like. What is hormone therapy? What does this mean?
One doctor said to me, you know, blokes are basically machines that run on testosterone. So when it's suppressed or blocked, you just kind of feel a bit empty and hollow and lack energy and drive. The fatigue is probably one of the most difficult things to manage. Some men get really bad hot flushes and sweats. I was luckily spared that side effect. But, I mean, it's literally the same drug that they give trans teens who are transitioning to block the masculinising effects of puberty. So, you know, that gives you a sense of how kind of profound its impact is. And it can actually, I mean, men over time can grow breasts, their genitals shrink. It is almost like this kind of involuntary gender reassignment.
Yeah, involuntary gender reassignment. And in the book...
And I mean, and it's crazy to think of it, because we prescribe ADT so regularly. But when you think about a patient experience of ADT, and you're right, you dream of a time when we can successfully treat advanced prostate cancer without the horror show of chemical castration, and not treat patients in the way pedophiles or rapists are punished in some jurisdictions. Strong words, aren't they? It just makes you think this is the experience that patients are having.
And the problem is, as he writes that, I think to myself, what do I say to patients when I'm starting a man on androgen deprivation therapy? And I do talk about, obviously, hot flushes and fatigue and a bit of weight gain. I talk more about depression, mood swings and stuff like that as well. But I find that listening to you, Tim, it's such a vast underestimation of the impact. So can you talk to us a bit more about that?
Yeah, and look, I understand it's a dilemma, because, I mean, you don't want to scare men off what is a very effective treatment, and that's something I wanted to be really clear about in writing the book. I'm not trying to discourage men from following the advice of their physicians. But yeah, I think if I was given a better sense of just how far-reaching the impacts were, you know, we could have better prepared for it. I think seeing a psychologist really early on, seeing a men's sexual health therapist really early on to try and maintain some kind of sexual function would have been really important. Exercise is probably the single biggest thing that mitigates so many of the side effects of hormone therapy. So, bone density, muscle mass, even sort of elevating mood. I often say if there was a drug that did for us what exercise does, it would be huge news.
Yeah.
And I've been lucky to take part in a couple of exercise studies which have had enormous benefit. But yeah, I can remember one. Well, I think the big thing was I just had never heard of this. And, most of us are familiar with most cancer treatments. We know people who've had chemotherapy and surgery and radiation. And I was kind of shocked that I had never heard this discussed. And it sort of seemed like a bit of a dirty secret or something that I just felt like needed to be dragged out into the light. And, blokes aren't great at talking about this kind of stuff. And also, I guess, historically, it has been considered a bit of an old man's disease. And perhaps that's why it was kind of less, I don't know, like more acceptable to people somehow that this was done to an elderly patient population. But, I was 50 when I was diagnosed. So, yeah, it was a huge blow to pretty much every aspect of my world. Relationship, career, mental health, physical well-being. It's also an incredibly efficient and effective treatment. It's a simple injection every month or every 3 months. And, there aren't the sort of obvious disfiguring effects of, things like surgery or chemo. But yeah, I just think men need to be better prepared and better supported to mitigate those side effects and try and maintain quality of life.
Yeah, it's important, isn't it? Because I think sometimes you can explain these side effects to a patient, but nothing quite prepares you for the experience of it, which is why I think it's so important to have all those support networks ready to go from the outset.
We just don't do that, though, do we? I mean, I think there are reasons why. Tim kindly pointed out, you all seem very busy. Yes, however, because much of this is very predictable, and we should talk about the experience of younger patients versus older patients as well. But because it's quite predictable, why when the moment we write the prescription, don't we already have, well, here's the checklist, social worker, prostate cancer specialist nurse, psychologist, exercise, dietitian, et cetera, and you can pick and choose from them, but at least there should be a suite available, and, these are things that it may help you through this, or online resource, and et cetera. So, and you might think, oh, well, look, that's just like a pipe dream of, we'd all love to have all these things available for our patients. But, in Australia, we do have GP care plans, for example. When a patient's diagnosed with prostate cancer, there's a resource there so they can get access to things like allied health support for dietitians, exercise physiologists. With this diagnosis, you get 5 or 6 visits a year. Now, the GPs have to write the care plan. So I don't know, maybe we should be able to write the care plan, because what I usually say to patients is, if you go to your GP, he or she will be happy to write a care plan, and that will unlock your access to a dietitian and an exercise physiologist. But we need to maximize the opportunities we have, and then think, okay, what about the other stuff that Tim writes about, like, for example, psychedelic support or other strategies that maybe are not widely available, or uninsured patients may have some access, etc. But there's stuff out there that is available that we don't always trigger, don't you think?
Absolutely.
Yeah, well, I think it was about 4 years into my diagnosis, I discovered I qualified for a care plan. And, by that time, I was fortunate, my wife's an acupuncturist, and she's pretty well connected in that world of complementary therapies. And she worked at a place called the Living Well Studio, where there were physiotherapists and, masseurs and a nutritionist all working in the one facility. And so I was very quickly able to kind of assemble a team of my own. But I thought, why couldn't the diagnosis trigger the care plan?
Yes.
And, there's probably a bit of a risk of sort of overwhelm, perhaps, for the newly diagnosed patient to sort of be sort of presenting too much too soon. But I think, as you say, if there's sort of a suite or a menu and an explanation of how beneficial things like exercise can be, even if there's a short delay in some cases. I know sometimes treatment needs to start as soon as possible, but even if it's a matter of a few weeks, if you just had the opportunity to get into a bit of a program of exercise and healthy eating, what they call prehabilitation, which is a term I only recently discovered, and kind of getting you sort of fit and battle hardened for this huge challenge you're about to face, that there were some positives to kind of go along with all these, debilitating side effects, that it would better prepare the man for the journey ahead.
And so Renu, he's written nicely about the strategy he came up with.
Yes, absolutely, and I think we should let him explain the.
Yeah. So meds. Talk to us
meds.
about meds, Tim, because I think listeners to the podcast, whether you're patients or clinicians, can learn from it. Because there's a suite of stuff, but you have identified 4 key components to improve your well-being or your experience on androgen deprivation therapy, which I'm extremely struck by, and I'm going to see how can I support my patients by having a meds, MEDS type approach. So yeah, tell us.
Yeah, thanks. Well, I think there was a point where I was suffering a bit of information overload and trying to sort the wheat from the chaff in terms of, disappearing down wormholes on the internet. And as a journalist, I guess part of my skill set is synthesizing a lot of complex information and trying to put it in a way that's accessible to the average person. And I guess I play with words. It's kind of what I do. And so I came up with this acronym, MEDS, MEDS, and my personal self-care mantra just became, I have to remember to take my meds every day, which stands for meditation, exercise, diet, and sleep. And those 4 things became the pillars of my self-care. And, I always hasten to add, they're not intended to replace conventional therapies, but, to complement and to, I can't see how there's a downside to any of those things. I don't want to be someone giving spurious medical advice. But yeah, it's difficult to see how any of those things could do anyone any harm.
I think that's good advice for anyone really, Tim, to lead a healthy, well-balanced life.
Yeah, and I think it also became a healthy, sort of helpful shorthand, because I'd have so many people ask me. I sort of had all these people coming to me for advice, and I would say, look, I'm not a doctor. I can't give you medical advice, but this is what I do. And rather than having a lengthy conversation every time, I would synthesize it down to take your meds: meditation, exercise, diet, and sleep. I think sleep is one we kind of overlook sometimes too. It's a bit less obvious, but if you have good quality sleep, it's going to really stand you in good stead. And sometimes...
Let's go through the 4 things then. So sleep. So what does that mean to you? How much sleep do you treat yourself to?
Well, look, as a bloke with prostate cancer, I have pretty broken nights getting up to go to the loo, and that was a real issue. And it was probably one of the first red flags that something was awry. I'm on a trial for medicinal cannabis, the Quest initiative through Sydney University. And I found the oil just a wonderful thing for sleep. So I could, take a few drops of oil before I go to bed, and instead of getting up 3 or 4 times a night, I might get up once or twice and occasionally sleep through, which is a great gift when you're used to having broken night sleeps. And then M is meditation, which I was fortunate enough to have some experience with Vipassana meditation before my diagnosis. I actually went and did a 10-day retreat when my wife was pregnant with our first child as a preparation for parenthood. And as soon as I got my diagnosis, I just had this instant knowing that I've got to get back into my meditation practice. And that's been a great blessing. I think I've done 3 of those 10-day retreats since my diagnosis, and I have a pretty solid daily practice. And then I imagine you guys are pretty well versed in the evidence around exercise, and particularly
Tim, before you talk about exercise, so meditation, and so have you any tips for patients out there about resources? And we can put resources in, or maybe you have on the Tim Baker website or by Tim Baker website.
Sure. But I think it needs demystifying, because I hear a lot of people say, I couldn't meditate, and I don't really believe that. I mean, there are some really easy, simple, guided meditations. I've had a lot of blokes contact me since the book came out. How do I get started in meditation? And I'll usually send them a link to a short 10-minute, what's called a yoga nidra, which is just a lying meditation. There's a risk of falling asleep, but that's not such a bad thing. And you just sort of scan the body from head to toe and back again, relaxing each part of the body. And people will complain they've got a busy mind and they can't sit still or whatever. But the meditation practice is really just observing the breath and, noticing the mind wander, and then gently taking your attention back to the breath. And so, the fact that your mind is wandering is not a problem. You know, it's not something you have to fight against. You just notice that it's happened and you come back to the breath, and that is the practice. You know, the practice is noticing the busy mind and just gently bringing it back to the breath. And over time, you know, that focus on the breath, you know, might last 10 breaths, and then it'll last 30 breaths, and then 5 minutes, and then 10 minutes. And then before you know it, you're sitting for half an hour. And it's just something you can do every day to just stop that cycling anxiety that I think, you know, any cancer patient would be pretty familiar with. And it's been an absolute blessing for me. I'm not sure how I would have got through the last 7.5 years without it.
Fantastic. We'll put a link to that video we'll get from you. And exercise, you're right. So exercise is something we know about because there's been traditional oncological evidence of the benefit of exercise. And of course, many of our patients are not 50-year-old surfers. Many of them are older men. But so what's important to understand when we talk about exercise, in my interpretation, is that you just need to take your current level of activity, and as you start ADT, you just need to do a bit more. So if you are an 83-year-old man who, you know, has bad hips or and doesn't do that much exercise, you know, he just needs to go for a walk 10 or 15 minutes a day, and the exercise physiologist will sometimes build in just a little bit of resistance. Why don't you just do a little bit of lifting of some bags, et cetera, et cetera. So for people out there listening to it, it's not like you need to be like Tim Baker and, you know, do more surfing or this or that. The whole principle of exercise, which is very well developed now, a well-developed science with superb exercise physiologists around the country, and the ADT industry do support some of this, as well as GP care plans. All you need to do is, whatever it is you do a bit more. Would you say that's it's not like you need to be suddenly a marathon trainer or a surfer? Or
Yeah, absolutely. And I think that supervised exercise with an exercise physiologist or a physiotherapist is really key, because that fatigue and lethargy of hormone therapy can really, you know, get in the way of your best intentions. You know, I still have days when I walk past, and I say this in the book, you know, I walk past my weight set and my Pilates equipment and my exercise bike and go lay on the couch, you know. But working with a qualified exercise physiologist and having someone just kind of crack the whip a bit, and who also has that very, I guess, you know, qualified understanding of what's appropriate for your level of physical fitness, I think is really key. A lot of the universities have these great cancer exercise clinics with their 4th year exercise physiology students. And I did that through the University of Queensland early on. And that experience was fantastic, working with a couple of young, keen exercise physiology students. And they were just egging me on and, you know, making me go a bit harder than I'd gone last time. And yeah, having that kind of support, I think, is really essential.
Yeah. And I think, you know, the other thing that exercise does is, you know, it allows some social interaction, and it allows fresh air. It allows sort of, there's so many benefits from starting on a regular exercise plan. And I think the great thing about the meds approach is that all the different elements kind of interplay. You know, if you meditate, eat better, and exercise more, you'll most likely sleep better. And all of those things kind of benefit each other, and in a very nice way, which is why that's such a great thing to keep in the back of your mind. And
I think if there are patients or loved ones of patients out there listening to it, or indeed clinicians, you know, it's not difficult to organize exercise physiology. It's in the regions as well. There's a website, the ESSA, I can't remember, we'll put links in, but talk to your GP. So I think listening to Tim's very important, because it's such a key component of improving well-being on ADT, and his personal story really reinforces it. So people, you know, have a look it up. It's not difficult. What have we done? Meditation, exercise, diet. So
this is an interesting one, diet, isn't it?
In reading the book, Tim, it struck me that you're quite serious about the diet, and some of it looked a little bit like hard work to me, just to say that. Or
Look, I came out of the gates really hard on the diet front, and it probably was a bit extreme. I know my wife was pretty alarmed because I lost 15 kilograms in the first month, which I don't recommend to anyone.
Yeah.
You know, I could probably afford to. I was 95 kilos. I'm about 5'10", 175 centimeters. So I could definitely afford to drop a few kilos, and 80 kilos was probably closer to a healthy body weight, but it was so sudden and so dramatic you know, when people see a cancer patient lose a whole bunch of weight, a lot of alarm bells ring for people. So if I had my time over, I might take a slightly less extreme approach. And I have sort of moderated my approach over time. I now describe myself as a flexitarian,
Which is fine.
Having taken on vegetarianism, veganism, a ketogenic diet, and all these different things. Over time, I guess you realize it's a marathon, not a sprint, and what things are you really prepared to go without. And, you know, it's like that. There's a meme going around on the internet at the moment. You know, if you replace your morning coffee with green tea, you can eliminate 80% of the joy from your life.
Yeah.
And, you know, and patients will often ask questions like that. I mean, ADT patients, but also patients on active surveillance for prostate cancer or newly diagnosed with localized prostate cancer who need treatment. They'll say, you know, what can I do in my lifestyle? What about diet? What about supplements? And I have a very open mind on these things, you know, that most strategies, even going into the naturopath, and you talk about naturopaths in the book, these won't do any harm. They can improve your well-being or your sense that I'm doing something myself. But I also often quote my fellow countryman Oscar Wilde when he says everything in moderation, including moderation, and that it's okay, you know, to drink red wine, a glass of red wine, a cup of coffee, and everything. But, you know, getting the BMI under control, you know, understanding what your cholesterol is, all these things that tend to avoid cardiovascular problems as we age, also, I think, significantly improve cancer outcomes and well-being. But I think, yes, I suppose my take home on your diet message was, you know, take an interest in your diet and do strategies to improve your wellness. But it's okay to be a flexitarian, as you said, you know, but as a pillar, I think, as you describe it, of your strategy for dealing with ADT, it's an important one.
Yeah, I'm a big fan of Michael Pollan, the American writer who's written about food. He's also written about psychedelics, but you know, he's got a great little catch cry: eat food, mainly plants, not too much.
Okay.
And you know, when he says eat food, we go, well, yeah, but he means eat food that your grandparents would recognize as food.
Yes.
You know, not highly processed, modern convenience foods. I quite like that.
Mainly plants
and not too much.
Love it.
I like that. That's good.
So that's meds. And actually, you just mentioned psychedelic.
Yes,
because
you know, that was interesting because you do. Yeah, there's a great bit on your podcast and also in the book when you talk about your first experience with psychedelics, and you know, you go and visit this therapist and you take the medication. You sit there with you lie down with your headphones on and you're just waiting for the effect to happen. You know, the kind of are we there yet kind of concept. You know, when's it going to happen? And then you interestingly talk about all of a sudden this kind of bitterness and resentment that you felt towards that initial urologist that gave you the diagnosis kind of reared its head, and you sort of made peace with it at that time. And tell us about that. And was that a turning point, do you think, for you?
Yeah, I think it really was. I mean, when they talk about psychedelic assisted therapy, they really emphasize the importance of set and setting. So, and that means setting an intention and being in a really safe and supportive setting. And, you know, we should say this is illegal at the moment. Hopefully it won't always be. And so my intention that I set was to take myself back to that moment of my diagnosis and try and release whatever sort of trapped trauma I might have been carrying from that. And I did feel like I had some sort of, you know, PTSD as a result of the diagnosis and feeling like it was given in a bit of a abrupt or insensitive manner. But in the midst of my psychedelic therapy, all I felt was just this overwhelming compassion for my urologist. You know, like, oh, you poor man, that must be so hard doing that day after day and having to give that kind of news. And yeah, my heart really opened to him, and it was a real healing. And you know, I don't think hanging on to those kinds of feelings really serves anyone, you know, carrying some sort of resentment for someone who's, you know, trying to do their job to the best of their ability. So it was a great healing. And I do think the psychedelic assisted therapy has an enormous amount to offer people, particularly dealing with terminal cancer, and the research around psilocybin and terminal cancer patients is incredibly compelling as well.
It was a great little insight for me because, as doctors who give patients terrible diagnoses, at that moment in time, we do inflict trauma. And we don't often realize it. We always try to do no harm, but at that point, we actually do a little harm that can really persist in a patient's experience of their illness.
One of the I've talked about this in the podcast before. Pat Walsh, a great doyen of prostate cancer surgery, talks a lot about listening to your patients, and he's written about this. He's written an article about it, and what I find in listening to patients is that you completely modify the way you deliver information. It's just disappointing that it takes me 10 or 15 years of looking after prostate cancer patients that I discuss these matters now in a different way, but it's because it's evolved as I listen to my patients. And some of them, you listen to patients who come for a second opinion and they tell you what they were told, and it clearly upsets them, and you mental note to yourself, right, I sometimes say something like that. But isn't it very disappointing that as an industry, as people who break this bad news, who create PTSD for patients, etc., that we haven't got very sophisticated training in how to deliver this? We haven't, in medical school, we should have oncology patients telling us this is how you need to talk to us about this. So I still think, in fact, it's shocking sometimes listening to the patients telling stories about how cancer diagnoses and prognosis and treatments get described to them, Tim. And I think that's part of the message on the podcast today is we need to do much better. We need to have much more awareness of how we, the receiving end of it. And of course, many of us have been on the other side of it, receiving information about our family or loved ones. And again, that's a learning experience for me, because I think, how would I prefer to have this explained to me, or what support would I like to have in place?
And I think even more important now that we've been through a pandemic, and now a lot of consultations are via telehealth. You're not physically in the same room often with patients. So I think we have to, again, think about how we're delivering this news and what happens to them on the other end when we hang up.
You know what's interesting about that, and we talked about this during the pandemic, is, you might think, okay, it's not very personal, because you're not there with the patient and so on. But I remember having someone on who said, oh, hang on, I would much prefer to find out this news at home. It's like when you get dumped by your girlfriend. You can cry in the comfort of your own bedroom. Instead, you have to walk back out to the waiting room and pick up an appointment for the next thing and go down to the car parking meter, etc. Some people, I think it can be horses for courses. The environment in which these sorts of things are discussed, we need to individualize for patients. I don't know, Tim, have you any thoughts on that? Because you do describe these hospital environments and doctor environments, and the day you fired your oncologist is a great bit of the book as well. But I'm often transporting myself to our physical environment in the hospitals or in the consulting rooms, and how it must appear to patients, or how we can improve that.
Yeah, look, I think there's a few things that come to mind. There's a lot of evidence or interesting research around the mental health profile of oncologists and doctors themselves. And I think, that's an issue that needs talking about. And, it's hard to be really empathetic when you're dealing with some sort of mental health issue yourself. And so oncologists and doctors need to be able to talk about their own challenges in that area, and for that not to be stigmatized or not seen as any kind of blot on their career CV. And then I think, as a patient, the most comforting thing to me is just to get a sense that the person I'm talking to really cares. And I know compassion fatigue is real, and there's perhaps a protective instinct to not invest emotionally in every patient, because how can you and continue to do your job? But if sort of emotional distancing is a protective sort of strategy, it's not really working, because the research would suggest that oncologists in particular suffer fairly poor mental health. And so perhaps allowing themselves to feel the full range of human emotions in those challenging times might be better for them as well as their patients. One of the nicest things an oncologist ever said to me was when he got my latest scan, he said, "This has made my day." Oh. And it was just that simple message that this mattered to him, that it just meant so much. And I think, you're really looking for things to hang on to for comfort and reassurance. And, sometimes the physician might not realize how much their words mean, but that simple statement that this has made my day was just so precious. It meant so much to me. because a lot of times it does feel like you're being treated with a bit of sort of cool professionalism, and that you are sort of on a bit of a conveyor belt, I guess.
Yeah.
I've got goosebumps listening to you. And one of the things I remember a patient's wife saying to me many years ago was, as he was going into the operating room and she was dropping him off in the hospital, I turned to her and said, don't worry, we'll look after him. And I looked her in the eye and walked away. And as she said to me, that was the most important thing, because she was waving off her husband. And she said, whereas I wouldn't always do that. And, but she said, you looked at me and said, don't worry, we'll look after him. And she said words like that are incredibly important. They ring in your ear. It's the reassurance, etc. So we need to reflect on these words very carefully. I think maybe you need to write a further book about communication, to be honest. That is essential reading. And look, in a moment we want to wrap up by talking, very optimistically about some of the momentum you've building and some of the stuff you'd love to see happen to support patients around the world in this setting. But before we do, I wanted to ask you about your experience with support groups, because this was tough reading in the book, I have to say. Now, of course, you've given a great shout out to PCFA, great friends of ours who do support patients brilliantly in this country and support research and have fantastic nurses, and they also support the patient support groups around the country. And we always recommend patient support groups, but I find the experience can be very mixed. They're always great, but individual patients have very different experiences of a support group, and you write about that in the book. Do you want to talk a bit about support groups, either the in-person support groups or the online support groups, and your perspectives on their value?
Yeah, for sure. I mean, I've kind of had mixed experiences. There was a great online resource which has since closed down, that was run by a gentleman named Jim, whose surname eludes me. And there was a great system where, men could sort of nominate themselves as mentors. And so a newly diagnosed patient could contact one of them and just have someone to kind of talk to and ask for advice. And there was forums where you could post questions and have people respond. And that sort of peer support, I think, was really terrific. When I went along to a physical support group, I didn't have such a positive experience. I was probably the youngest man there by 15 or 20 years. And there's just seemed to be this complete prohibition on discussing anything kind of holistic or integrative. And even those words seem to trigger great alarm amongst some members. And I'd kind of get howled down when I just say something as innocuous as, I've tried to take quite a holistic approach to managing my health. And there'd just be this murmur of disapproval around the circle. And, oh, no, you can't do that holistic stuff, mate. No, you get yourself in trouble there, And so that was a frustration. And so I guess I kind of had an appetite for a bit of an alternative support group where people, you don't want people pushing snake oil. And I understand how vulnerable cancer patients can be and how easily they can be taken advantage of. But I guess if there are a few younger men and a few men who are a bit more open-minded around things like diet and exercise and psychological support, and even having a bit more of a candid conversation about the effects on masculinity and sexuality, maybe I'm a bit different. I do have a bit of an appetite for that sort of emotional candor, I think. And that's not everyone's cup of tea, and that's fine. But yeah, I didn't really find my people, I guess, in that regard.
Maybe it was the younger thing. And, there is
I think there is a generational thing.
Yeah, I think so. And it's also, I think, because of the magnitude of the side effects of ADT in younger people. I think that's kind of well recognized, but it's not to say older men cannot be just as devastated. I've had patients who've had shocking depression and mood swings really affecting their relationship at all ages. But the support groups tend to have older men for sure. And therefore many of our older men really find them. So, and everyone is different. Every patient is different. Every support group is different. Yeah. And is there a need though, Tim, I suppose, for better resource for younger men with metastatic prostate cancer, knowing that there is some additional burdens there? I think here in Melbourne, we did have do have a younger men support group, actually near Peter Mac, near Carlton Football Club, that was supported by the football club, I think. I must see, is it still out there? We'll put a link in if it is. Do you think there is that a thing? Is there something that younger men need a bit more?
Yeah, I think so. I mean, what was I going to say? I had something on the tip of my tongue then.
support groups.
Yeah, support groups. Yeah, I think it would be good to have a sort of people who had a more similar experience to you. I'm lucky I've got a pretty good bunch of mates who are all, you know, pretty up for a good, honest chat, and people who I could reach out to in times of need. But, you know, not every man has that. And I think we could definitely do a better job. I mean, I was talking to Anne Savage from the PCFA about the idea of running surf lessons for younger blokes with prostate cancer, just as a sort of feel good thing, and getting them in the ocean. And, you know, the ocean is a well documented lifter of mood, you know.
Yeah.
And the physical benefits are really profound. You know, so that was one idea I had. I haven't gotten around to actioning it yet, but who knows, that might be something we do over summer. But yeah, I think there's so much we could do to recognise the greater challenges of younger men, and maybe a specialist sort of support group for those kind of blokes would be a good thing.
And Tim, you know, back before all of this started for you, you were a surfer, you're a journalist, and how's that passion for surfing kind of seen you through your journey, and is it still a big part of your life now?
Yeah, absolutely. I've just come back from 10 days in Bali and had a great few days surfing, as well as going to the Ubud Riders Festival. So I was really lucky. I think when I was diagnosed, my 9-year-old son, Alex, was just in the early stages of a really acute case of saltwater fever, I like to call it. And he didn't really care that his dad was going through chemotherapy. He would just drag me out of bed and make me take him surfing. And that was such a source of joy. And I write about that in the book with great fondness, you know, paddling out into the ocean. And it was this wonderful sort of thread to my old life, you know, and it's been something I've been able to maintain. It's a bit harder to make myself paddle out some days when I'm feeling lethargic, but I've learned if I can just get in my wetsuit and put my board under my arm, it's like old muscle memory just kicks in, and then I'm kind of, it's sort of like a connection to my old self, and I can happily trot down the beach and paddle out. And as soon as I'm in the ocean, I'm just like, oh, thank goodness I did that, because as soon as you leave land and paddle into the brine, it's like you leave your landlocked problems behind, and you're just another happy surfer bobbing on the ocean, gazing out to the horizon, waiting for a sweet wave to come your way.
We can just picture it as you're speaking.
Well, Tim, look, thanks so much for joining us. Thanks for telling your story. And the book's called Patting the Shark. It's, you know, where are we now? Mid-November. It's easy to buy, as of course, online, but it's very prominently in all the big bookstores around Australia. I went in and bought two copies in my local readings, and it's coming up to Christmas, folks. Get out there, buy a copy yourself, or tell your loved one to get you a copy. It is a fantastic story, but I think if you're in the prostate cancer business or industry, it's very, very important that you read stories like this so that we can do a better job looking after our patients.
I gave a copy of your book to Howard Soul at the PCF, so he'll be reading it now. And
Howard's a huge leader in prostate cancer research from PCF in the US, so you gave him a copy.
I gave him a copy.
Okay, we'll have to text and let him know. And that's it. So I can do nothing else more than recommend Patting the Shark by Tim Baker. This fantastic. I think it should be called Punching the Shark. He did a bit of a Mick Fanning he is doing a bit of a Mick Fanning on his prostate cancer, because your PSA is bottomed out. I saw you tweeting about it, and you're off ADT
he's
at the moment.
The shark and
he's smashing the shark.
Learning to live alongside it.
Yeah. I think we've called a truce. Hopefully.
Yeah. Well, keep writing, keep surfing, and we look forward to more from you, Tim.
Yeah, thanks so much. I've really enjoyed the chat, and it's incredibly gratifying. The level of interest, particularly you know, the medical fraternity have taken in my story, and hopefully we can make some meaningful change.
Fantastic. That's all we have time for here on GUcast this time around. We'll put lots of links in the show. We look forward to seeing you all again soon. Thank you very much.